Good evening, sir.
Good evening, sir.
Rajiv sir, good evening. There is a mild change in today's program,
Yeah, I saw that. I saw that just now.
So
In
there
fact,
is some challenge for that.
we can just discuss the difference between a small node file, giant fibrinoma, and sister sarcophagus file. It's just a small discussion.
And that is also possible, sir. Otherwise, I was thinking like I will have a question and answer session or to how to prepare for the OSCE. That was the other idea.
That would be very nice. That would be very nice.
So no need to have any slides. We will have the discussion with the faculty. As a faculty, how do you set OSCE and what is the idea of asking the questions? Like how to safely answer like that. This way the plan will be, sir.
I think that's wonderful.
So because I just discussed with Kanna sir also, he said to get a last minute thing will be a challenge. So we will have it like this. He also agreed. And we'll give a few minutes, sir. Let others also join. Yes, sir. Good evening, ma'am. Thank you for joining. Allow us a few minutes, ma'am. So, good evening, esteemed faculty. We have some challenges this week for the student because she has got held up in a sickness and then she could not come to the class for some reasons. So, with the permission of the faculty, we'll be having a very brief discussion on how to prepare for the OSCE questions in the exams. Because most of the universities have also moved into it, and the national board also have made OSCE as a mandatory thing. So initially, I will be requesting the faculty give some guidance to the students, and then later, if time permits, we'll have the students also to ask questions or clear their doubts from the senior faculty. So today we warmly welcome Professor Madhumita ma'am. She is a professor of surgery and head of the department from Diamond Harbour Government Medical College, Kolkata. And we have our own faculty, Dr. Rajiv Sahai sir. We have Professor Narendra Gupta, other senior faculties who have joined. I could see Dr. Sentamil Selvi. And whomever are in the teaching side are welcome to share your thoughts also. Let me set the ball rolling now. I will ask Dr. Rajiv Sahai sir to request him to switch on the video so that we can initiate the discussion and we'll take it further. Sir, like I'm sure you would have been examiner for many years now, both UG and PG, and I'm sure you are also approved question preparation team for the exams of MS General Surgery A as well as DNB in General Surgery. Sir, can I ask you a question? Like, what are your core ideas? See, when you set up a question for a General Surgery OSCE, what are the things you have in mind, or what do you expect a question should comprise of, sir? Because I could see in exams you have questions on imaging, questions on clinical case discussion. On what basis, as an exam, do you set up the questions, sir?
Right. Like we all know, Osce is clinical based. It is a theory based clinical exam where, where we don't have patients. So we ask day to day questions which a surgeon comes across. He will come across a blood report. He will come across some investigation like X-ray. He may come across some instrument. He will come across some form of suture. So all this day to day, if I'm taking the round and I see a chest tube, I want to know whether the student knows what is this, why was it inserted, how is it inserted, how is it taken care of, how do we remove it, all that kind of things. So an OSCE would be based on, say, just a picture of a chest tube or an X-ray showing any hydropneumothorax or pneumothorax where a chest tube has been put, and the questions are based that.
Fine. Sir, from the candidate's perspective, I could see Vipul and others also joining now. From the candidate's perspective, what is that they should be preparing upon, sir?
So
Like, do they go
wish,
through the theory? Do we have the regular textbooks? What is your advice, sir?
no textbooks are required in OSCE. It is what you work in the ward, what you have done in last 3 years in the ward. If you have got a Foley's catheter, you should know exactly. If it's a child, what is the size I'm going to put? If it's an adult, what is the size? How do I put it? How do I remove it? What are the complications of putting it? What are the complications of removing? Suppose a catheter is put, what are the difficulties a patient can have, and how do we treat that complications? So basically, it is no textbook. It is just what you do in the wards. What you do in the wards, you do in the OPD, you do in the OT. It is just that.
Sir, also, sir, like in theory questions, we have clear demarcation. Like if it is a 10-mark question, they give 3 plus 3 plus 4 or 4 plus 4 plus 2. In ASCII, some ASCIIs, they have only 2 questions. Some ASCIIs, they have more than 3-4 questions also in the stipulated time. How the marks are given, sir?
So actually, this is very variable. It is depends on the examiner, but we usually give more weightage to the first question which is asked, as whether the student can identify the core problem with that picture or that situation. So if there is a chest tube, the core problem is how do you put in a chest tube safely? That is the core issue. Removal, all that kind of supposed block, they are subsequent to it. So this question will carry the maximum marks.
Okay.
Yes, that is that way.
So also, sir, like generally what happens is the student is allowed to use one A4 sheet on one side to complete the answers, because many things are scanned and uploaded for the examiners for correction. So like they need to be descriptive in that 5-7 minutes allotted to them, or they can like write in a bullet so that is accepted, sir. Do they be to be very abstract or descriptive is the question, sir?
It is, we look for the keywords. Like in any journal, there are keywords. Every exam has got certain keywords. Like triangle of safety. If he mentions triangle of safety, I know what he's talking about. He may not describe it. He may not say this is the posterior lateral border of pec major and all that kind of stuff. But he just says triangle of safety. It is accepted that he knows. So
please go ahead, sir.
So we don't. I never look for them answering in as if in theory. It is not required. Just that word, that important word, should be mentioned, and that's how you get the marks.
Okay, sir. And then a candidate, a beginner, do we recommend any books? Like those days we used to have this Pice Handicraft of Surgery, something like that, where many short procedures. Do we have the Pice? Do they still come, or what is the current recommendation?
You don't get Pice, but there's a book called Surgical Recall.
Okay.
It's an American book which tells it's basically for interns and junior residents on how to write the history, how to take out samples, all that. But my point is that if you have worked 3 years in the ward and seen the patients and managed them, you can get through the OSCE. A bit of theory, of course, is required, but I mean, these books are just adjunct to help you. So.
And how does the NMC look at, sir? Do they have separate pass for the OSCE, or how do they look at, sir?
Right. No, OSCE and the theory marks are added together for passing. So you don't have to pass.
They have a separate pass, like if it is in this component of OSCE also need to be passed, or how does it work, sir?
No. The theory, both the practical and the OSCE, their marks are added, and it should be more than 50%.
Okay, so it is not a singular component pass, so that they get a pass. So overall, if they are scoring 50% of the full marks approved, they generally pass.
In fact, OSCE is a ladder to pass, because most students do very well in OSCE, and so it's a ladder to pass.
Right, sir. And then, like generally, sir, these students are made to present in the department, in their ward round, to the assistant professors, to the chiefs. So the communication happens in case presentations often. So how do someone get trained in OSCE or get familiarized with OSCE?
Actually, what I tell my students is that suppose you're going to, let's go back again to a catheterization. Suppose you're going to catheterize this patient. So how do you decide what is the number of the number of catheter we're going to use? What is the purpose why you're using the catheter? All these questions should be answered as he goes along. He sees that the patient is having acute urinary retention. He'll arrange for the catheter, he'll arrange for the xylocaine jelly, he'll arrange for the gloves. How is he going to do a no-touch technique? How is he going to put in the catheter? How is he going to wait till the urine comes out before inflating the balloon? How do you fix the catheter? How do you ask the patient to take care of the catheter? How long do you leave the catheter? If there's a pericatheter leak, how do you manage? If there's hematuria, what do you do? So I ask them to go through these questions on their own. Sometimes we ask the juniors to ask the senior residents to ask the juniors these questions while they're performing. So this is just an ongoing process of preparation.
So it is more they work in the ward and they learn from their seniors and learn the process of what is happening as a standard operating protocol in the ward when they get a patient with trauma or when they get a patient with retention. That is what is. So students need not be scared about OSCE at all. Am I getting it right?
OSCE is a friend for them to pass.
Amazing. Sir, in extension to this, like a student also are asked about imaging questions, asked about clinical names, like say for instance, Raynaud's pentad or Whipple's procedure or something like that. So again, please go ahead, sir.
No,
what are those type of imaging based OSCEs, sir?
So imaging base is fine. A plain X-ray, basics of CT scan, basics of MRI, basics of mammo. That's why in our place we've kept a date Monday every Monday. We take the week's collection of CTs and X-rays, and we go to the radiologist and ask them just basics. How do you know this is a CCT? How do you know which is the pouch of Douglas or the hepatorenal pouch? How do you see for collection? All basic things. So this is an ongoing procedure. Students have to. No one can spoon feed them. About questions such as describe Whipple's or spleen saving Whipple's or what I dislike. This is not in OSCE. This is not for. I think I should judge a student what I knew during my MS exam rather than what I know now, because my knowledge in this whole year has increased so much. So what I knew during MS, my question should be based on that. And of course, after he passes, he's going to undergo 3 years training. But he has to be a safe surgeon. That is most important. If you don't know, say you don't know and ask for help. This I tell the students all the time. So in OSCE also, it's like that. If you have a patient of trauma, you do the ABCDE. Most important, saving the life is important rather than treating the patient.
Thank you, sir. Now I think we have Kanna sir also. Let me ask few questions
Sure.
to him also. Welcome, sir. Good evening, sir. So, sir, we just initiated the discussion on how to prepare for the OSCE and what the examiner expects out of the candidate in OSCE. Sir, very clearly mentioned, OSCE is like how things are done in day-to-day affair in the ward. That is the principal thing. It can be a procedure, it can be a imaging, or it can be a process of treatment or a clinical case solving. And then OSCE definitely helps the candidate to get a good mark so that they are in a better position to pass the clinical exam. Sir, I'm sure for the past 30, 40 years, you've been examiner to various candidates at MS and MCH level. Sir, OSCE is a new thing which is coming in, say, for the past 10 years or so. Of course, the British system had OSCEs much earlier. Sir, in your institution, especially in Banaras University, how do you train the candidates to face the OSCE exam, sir?
ಇದು ಗೂಗ್ಲಿ ಅಂತಹ ಪ್ರಶ್ನೆ ಗೂಗಲ್ನಲ್ಲಿ
Yes, sir. One
Am I
moment, sir.
audible?
One moment, sir. There is some disturbance. Yes, sir. Perfectly audible, sir.
Right. I think OSCE is one of the things which is there, which the Britishers they started that somewhere in 1975. Especially started probably
Oh,
University of
that
London.
early, sir. Okay, okay.
Yeah, it was too early. It was started, and
Mm.
but it was taken up by some persons, but majority of the people did not accept that. But now it is probably now all over the world, all over the globe. Now this is one of the, because this is more of an objective assessment which is there rather than just a subjective assessment. And I think in the OSCE, one of the very important thing which is there is that how does a candidate approach a patient? That is probably one of the most important thing, which is judged by the examiners there. That like if a patient, you are going to a patient, you may say, good morning, Mr. So-and-so, means you pay the regards to the patient there. If you do not show that courtesy there, then you probably lose the marks there. And when you are going to examine that particular patient, you have to tell that what you are going to do. Are you going to examine the abdomen of that patient or the breast of that patient, or you are going to examine the neck of that patient, and you have to take the permission. There has to be verbal permission for that, because all these communication skills which are there, all these things which are there, are taken into consideration for giving the good marks. So it is not only that what exactly you are doing. There's a patient is there, a patient of appendicitis is there, you are going to make a diagnosis of appendicitis, you are going to investigate that patient and how you are going to treat. So that is one part of that. But very other important part is what is the communication skills which are there, how you are going approaching your patient here. So that is a very important thing, and the student must keep in mind as if he's going to talk to some of his own relative which is there. So it is not just a patient there. And that is why, we nowadays even in our chief complaints, we never say that the patient has this. No, Mr. Such and such had this. So you are giving more regard to the patients rather than just saying that it is a subject is there. It is not a subject. And that is why the male and female has been now disappeared from the literature now. Now you do not say it's a male or a female. It's a man or woman is there, or a child is there, rather than saying that. And then another concept which I always say, that age is no wonder is there. That if somebody is having a 50 years or 60 years, you will not say he's an old patient. He is an old so-and-so person is there, not the subject. So all these, I think, etiquettes to the patients are very important, especially in the OSCE examination, which is there, and they are looked after by the examiners, that how you are approaching that. So that is a
Sir,
basic concept about that, yeah.
very, very important perspective you brought in, sir. I'm sure you also set questions for all the both MS and MCH level candidates. Sir, when you are setting OSCE, what are the principal core thoughts? Sir, setting theory exams is a different thing, and setting OSCE questions is a different thing. So what are the core things you expect a candidate to answer when you are setting up an OSCE question, sir?
I think basically OSCE is not a thing which is you are just going to mug up from the books.
Yes, sir.
It is showing you the practicality of that.
Okay.
So if a subject is there, or subject means the patient is there, or you want to ask, get out the diagnosis of that, or you want to treat that particular one, then you have to frame your question like that such and such person has come with this, and now your mind should open for that. It is not like that just mucking up the things that you are giving 1, 2, 3, 4, 5, 6 differential diagnoses are there. No, but if that differential diagnosis is there, it has to be according to what your brain is thinking at that particular time. So it is not only just that you have read from the book that this is probably that. It has to be a absolutely practically oriented. A patient is in front of you, and this particular patient has got these problems. So you are going to analyze if the patient has got only fever is there, or the fever with pain is there, or the pain came first, or the fever came first, or the abdominal pain is there, or distension is there. So all these things has to be put in a correct manner to find out that. So all these OSCE questions which are there, they are more of a practically oriented rather than a theory oriented questions which are there. And you want to take out from the mind of the student that if he gets particular type of the patient with him, how he is going to approach that particular thing. That is what now it is coming with the artificial intelligence. AI is coming in a big way for that. Yeah.
Yes, sir.
He's going to analyze that and giving that. That is why the people say that you have to be very careful once the AI comes, then where you are going to stand, you have to find out that. So it's more of a practical orientation rather than the subject or a
So it
theoretical
is,
one.
thank you, sir. I am to understand it's a clinical pathway. Like when you see a patient in the ER or when you receive a patient in the wards, how do you do and what you do in the logical process is to be mentioned in the right way. Sir, do you recommend any books for the students to prepare for OSCE, or standard textbooks and practical manuals are adequate, sir?
Well, I think for giving those things, there are several books which have come for that OSCE, which are there, which are available. No, the student has to muck up all those basic questions, no doubt about that. Until unless they
Yes,
know
sir.
about that, then they cannot go for their subjective assessment. So they have to know the basic books, no doubt about that. But
Yes, sir.
more practically oriented books are available of the OSCE also. And I think
Yes, sir.
they should go through those books also, apart from their main relevant books which are there.
Fine. So it is more or less like standard textbooks first, and then
Yes,
clinical pathways are the one which are more important thing.
yes.
Sir, we little move on to the short cases discussion from OSCE, because OSCE looks very straightforward. A student who has worked hard in the ward will not at all find difficult to pass the OSCE exams. Sir, when you are sitting for the short cases, like we are now left with only 15 minutes per short case, and they have to finish 2 short cases in half an hour time. So a candidate, does he write to, you expect the candidate to write a case sheet, or what is your expectation as an examiner, sir, in short case?
Now, if the short case is there, I will not like to listen too much of the no history of this and that.
Hey guys,
He has to give the positive histories which are there. So what
Yes,
are
sir.
the positive findings which are there? He has to narrate those rather than until as it is a very relevant, like a patient who has got a cancer of the oral cavity, he has to mention about the tobacco smoking, though it may be a negative history, but he has to tell about that. But otherwise, no history of, because half of the history which goes is the no history. In the short cases, probably no history probably doesn't have much of the role until as very specific questions are asked about that. And then I think he should write in his notebook, if he's writing that the main things which are there, not a very lengthy one like that, just the main things which are there. And in a surgical type of what we are going to deal is, the most important part is the loco-regional examination. He has to put his whole thing on the loco-regional examination rather than telling much about the in the general examination, 2 or 3 things which are important, but otherwise majority is like if the patient, if the student says just there is no pallor and there is no jaundice, that is, I think, probably good enough for a short case. But loco-regional examination, which is there, that has to come out in detail in the case of the short case. So that is probably the most important thing the student has to write. So the relevant history of the positive ones and the relevant loco-regional examination.
And thank you, sir, for bringing out all the vital points of short cases. Sir, do you recommend any textbooks for students to prepare for the short cases?
Difficult to say that. About the
No,
short
I'm not
cases.
asking to be on a
There are,
commercial point of view.
Hello.
we have been also reading for a very long
Speak.
time. Like the K Das is there. We have been reading for a very long time. Now,
Yes, sir.
what is S Das is there. So we have been, even when we were the students, we were reading that. So I think that is one of the good book. Apart from there are many authors which have come up with the books. They can go through that. Yeah.
Definitely, sir. Definitely. Now I move to a little bit to
So,
Rajiv Sahai.
so may I just put in a word?
Please, sir. Please.
Right. In short cases, suppose the patient, the student should first say, suppose it's a case of hyperspadias. He says, this is a case of hyperspadias. Then the questions come, why do you think it's hyperspadias? What is hyperspadias? How do you manage all that? Right? He has a lump. Suppose it's a case of sebaceous cyst. Then the questions come, why do you think it's sebaceous cyst? What are the differentials? So short cases go like this. History and all the thing is usually not asked in short cases. The student is supposed to know about it, but the examiner usually don't ask. In long cases, we ask the history and then say, now what do you think it is? So it's the other way here. We come with a diagnosis and then the management and the history is asked, relevant history.
So the student should be prepared for a taken retrograde presentation with the diagnosis asked upfront, and then how to support the diagnosis or how to exclude the other things. So a student should not be stumped once they are upfront asked the diagnosis also. A student should be prepared to take that way of approach to the examiners also. They should be mentally prepared to do.
Because they're different kind of examiner. But usually the examiners in short questions ask, okay, what's the case? This is it. So why do you think this is? How do you manage it? That's it. So
that way they go maximal discussion from then on, rather than having a baseline discussion on history of present, past,
long cases is important. Short cases is not.
Point is taken. Students, I think we are into the discussion for how to face the exams. Do anyone have any questions here? You are welcome to ask. You are welcome to ask the questions, because this is a time meant for you. As we have the classes challenge this week, we are continuing with this discussion. Any one of the student who wants to ask any questions here are welcome to introduce themselves and ask your doubts clarified by the senior examiners here.
So may I just put in another word?
Please.
I just wanted to tell them about theory exams also.
Please, sir, please.
In theory exams, we check this paper. There are about 300, 400 papers. We got to check about 4 or 5 questions. So it's not possible for the examiner to read all those, everything which is written. So what examiners do is they look again for keywords. Suppose the question is on bariatric surgery. He has to write the keywords that it is. What are the indications? Metabolic. Why is it called metabolic? What are the types of surgery? What are the pros and cons? And you don't have to write the whole thing. Those keywords should be highlighted so that the examiner knows that this person knows the theory. Because no examiner is going to read 300 or 400 papers of 4 or 5 questions each. So writing pages and pages of it makes no sense.
Point is taken, sir. Kanna sir,
I want to interrupt you.
Please, sir. Nishi sir, please go ahead.
Sir, in our advanced course in medical education, there is one topic that is death of the long case. So main motivation of the NMC is they want to replace long case with OSCE and OSCE with different clinical aspects. That is, for example, history station, clinical examination station, communication station, procedure station, and knowledge station. Knowledge station include treatment station and investigation part. So basically, they want to replace long case with all these components. And their concept is that assessment drives in learning in direction you wish. That means if you assess the student with this a particular protocol, the student will get the desired competency. And one more one thing of the one bad point of the long case is that here in that long case we never asserts the desired competency. We were asking the student that rarest syndrome, rarest cause, and basically the communication, how to talk with the patient, that was never assessed. So basically, they want to replace with this like foreign exams. For example, like foreign exam protocol, they want to prepare everything depend upon all these things. And in Rajiv Gandhi University for internal assessment, this is the first university, I think, they asked to take, they instructed to take the internal assessment examination depend upon history station, clinical examination station, communication station, and procedure station.
Thank you, sir. Thank you for bringing the actual thought process and the policies of the NMC for the. Now I'm going to make a tough question to all the examiners. I want individually to everyone to help the students. Sir, there are many students approaching us telling, sir, I did not clear my exam for the last 2 times. I'm much worried. This is my 3rd time, 4th time, like that. So I would like to hear from each one of you, starting from Kanna, sir. Sir, yeah, additional batch student, what are the extra measures they should take, and where are the areas they should concentrate more when they're appearing for the repeat exam, sir?
I think in any exam, there are few common patients. Like you will always get a patient with a lump in the breast. You will always get a patient with a thyroid swelling. You will get an abdominal lump. So I think they have to more concentrate on those particular things. And I think probably this is very difficult to say. Somebody, who has been appearing for 2 times, what he will do on the 3rd time, it is really difficult for that. But, once it is the 2nd or 3rd attempt is there, and if the examiner knows about that, then examiner also becomes a little lenient at that point, so that they are not going to ask very difficult questions from them. So I think passing in the 2nd or 3rd attempt, which is there, one should not go into very advanced type of things, what are the recent advances and all those things, because examiner also knows about that and is going to only ask about the basic things which are there. And if they can get through those basic questions which are there, very simple questions which are there, why does a thyroid move with deglutition? And rather than going for that, what are the various genes will be there in the case of the carcinoma thyroid? So all those things, I think the basic things which are there, if they prepare that and they prepare the common type of the patients, I think they should be able to get through it.
Very, very important suggestions, sir. Like concentrate on the basics and fundamentals rather than concentrating on advanced things. Rajesh sir, would you like to address this? One of the candidates have raised their hand. Will you please address to this? You also been examiner for more than 2-3 decades now. And what is your approach, or what is your advice to the students who have come as an additional candidate?
So 2 things. One is they have to pass the theory to be eligible for. So
yes,
passing
sir.
theory is the first step.
Yes,
now, sir. Students, the problem with the students is they want to know everything about everything. But I tell them, you know everything about something, the important things. There are 10 to 12 topics, starting from here, you've got the parotid, oral cavity, thyroid, breast, peripheral vascular disease, appendix, kidney, stomach, about 10 to 12 topics, 15 topics max. So they should know everything about these 15 topics. At least Bailey Love should be their aim at that point of. I don't want them to study and read anything else, any other book, just Bailey Love. In practical, again, like Sir said, most important is that those cases should be, because if you've done your theory well in these topics, you will do better well in this practical in these topics. They have to learn to examine these patients every day. Go to the ward if they are when they are preparing. Go to the ward, take a case of peripheral vascular disease, examine the patient, go back and read the theory, and then come back and read the practical, do the practical again. So it is a two-step. You see the patient, go back and read the theory, come back and do the practical again. So that is the only way. Some students have this problem of language, especially, and they are penalized for it, or the handwriting. I think it's very sad. Examiner should put in more effort to decipher the paper rather than just set it aside with a big zero. We are also to blame. We are very strict with our this thing, but that is slowly changing now. That is slowly changing now. It's much better. Most students are passing now because of this. Right. Thank you.
Thank you, sir. Thank you. So the message is loud and clear. Go back to the wards, see the patient by yourself. Don't leave the touch of examining the patients. Go back, read the theory basis of it, read the clinical basis of it, and then prepare yourselves on that basis of repeated examinations and repeated seeing of fresh patients. Very, very pertinent point. Can that XYZ person switch on their video and ask their question, please?
Sir, sorry to interrupt you there.
Nishi sir, please go ahead.
Sir, most of the time my observation that student is not concentrating on the remote or recent thing, but they are not able to reproduce the clinical, what is given in a clinical task. What are different causes? These basic points and clinical examination, when there is maximum candidate, I observed that they are failed due to this. They are not able to palpate the breast. They are not able to palpate the lymph node. Even PGs are not concentrating on all these points, all these basic points. They are knowing the molecular level or other investigation, but they are missing all these points, sir.
I could see someone, sir, please. Can that XYZ person please come in to ask the question, please? Is he there? And I could see one of the professors of cardiology joining this class. Sir, thank you for joining, sir. Please introduce yourself and share your thoughts, sir. I'm very happy to see a professor of cardiology joining. Welcome, sir. Abhay, sir. Sir, I never knew you were that XYZ person, sir. Very sorry.
I had changed it because of ASI elections.
Okay, sir. Okay, sir. Please, sir. What is your thoughts, sir? You want to
just give me a second. Okay. So 2 points. One, failure of the candidate. I have personally experienced going to Gujarat or multiple other places where they do not know English as the language. And that is where we have to give them leeway, not knowing, the local language. So this is a problem that happens time and again. I go to Rajamundry, they speak in Andhra language, and I don't know what is Andhra language, but they try to speak in English, and that is where candidates and examiners, not me, but others may like to fail the candidates. So communication with the patient, even when I take rounds in the wards of JSL Medical College, I'm at loss unless it is converted. So if I have to go as examiner to this place, I have to prepare myself to downgrade my questions to a level where the candidate can understand and the patient can understand. That's my first thing, that is for the candidates as well as for the examiners. The second is the short case. Ajay Khanna sir and the other person talked about it. See, the short case is designed at 15 minutes. The presentation should be intent on diagnosis. History and examination should support your diagnosis. No other history. They have already said that no history of this, no history of that does not matter, and may be ready to answer the questions. That's the way I'm looking at it, and then the things can go smoothly. So coupled both, it's a difficult situation for examiners, and the candidates have to realize that it's an extremely difficult situation. So be yourself and do the needful. Everything will be okay. As far as the last thing is concerned, that perpetual failures, I'll just quote one example of my going to Gujarat. And as an examiner, 62-year-old was still trying to appear for MBBS examination, was running a clinic, and this man knew everything clinically, but could not answer in English examination. And the problem was that the other examiners previous to me never conversed with him with Gujarati. So this man had failed every time, 18 times. I can tell you, 18 times. And I just had to tell him that you answer in Gujarati and we will see. I will translate it with the supervisors and we will see what are your answers. So he passed ultimately. Thank you so much.
Thank you, sir. Thank you. Would anyone like to ask any other question? Thank you, Abhay sir, for giving your thoughts on language issues. So they should express themselves to have assistance if they have a problem of the language. But as I'm also a convener of the exam, the National Board says you can appoint translators if the candidates ask for in advance. So generally, our own nurses or ward sisters help them to do the translation. But of course, National Board do not permit them to have an interpreter for attending clinical exams or anything like that. So I think that is the same with the NMC also. So with that, if there are any questions from the floor, you are welcome to ask. Madhumita ma'am, are you with us? No, right. So if there are, Nishi sir, you wanted to ask something, please.
Sir, in NMC, in foundation course only they included the language course. Regional
Yes, sir.
language,
Yes, sir.
local language, from first
Yes, sir.
MBBS.
Correct. No, but then exams, do they permit an interpreter, sir?
Yes, sir. Yes, sir. Yes, sir.
Okay. So patient examination can be done with an interpreter of the local language.
Yes, sir. Yes, sir.
I think as long as the candidate is appearing in their own medical colleges, this never becomes an issue. When they go for DNB to another zone center, but I am aware that DNB is also trying to reach them only to the nearby states rather than running across the country also. So maybe the examiners are also trained, and as we get older and older, we understand the students' capability and we try to bring out the students' knowledge back as much as possible to get the knowledge out of it, so that we try and give them a comfortable zone to do. Before we close, I will ask each one of you, Kanna sir, like if a candidate is having exams in 1 week, what are the things they should concentrate now? I don't know. It's a difficult question. Many students come and become very tensed up telling, sir, I have not finished reading this book, that book. They're very, very nervous. And we tell them, just go revise what you have studied. That's what I normally tell them. But what is the last minute preparation advice from you, sir? Kanna sir.
I think again, they have to concentrate on the common type of the patients. They should just go through that. And at that time, they should not go with a big books like that. And they should have to come down to certain books. You know, some of our colleagues, they have written very beautiful books. And one of our colleagues in this session also, he has written a beautiful book. I will not name his name, but just telling you that he has written beautiful book, and the candidate can go through that particular book before the exam, and I think he can get through there.
And we have a quick question to you, sir. Like many students have accumulated question banks from across various states, universities. They prepare question banks. At least in my postgraduates, they have about 500 or 600 questions. That is all is only possible, they are telling. I don't know how far it is true. Do you recommend reading based on the question banks, or what is your recommendation, Kanna sir?
I think based on our PG classes, which is there, they should go through our PG class, like they should pick up 2 or 3 cases of CA breast or a thyroid. I think everything they will get in that, in that 1 hour and 1.5 hours, everything is there. And that is sufficient for them to get through that, yeah. So my
So if
advice
you
would
have,
be to go through these PG classes which are there, Jay, yeah.
yes, sir. Abhay sir, I could see your hand again.
If you have worked in the ward, examining diligently, taking history, clinic examination, and investigating the patient as per the ward protocol or HOU protocol, you can answer everything. The problem that happens is that when exam comes, you forget what you have done in the wards. That is the biggest tragedy that happens, because the examiners will always support you what is happening in your ward and how you have gone about examining the patient, taking history and examining, investigating this patient. That's what I, as an examiner, always look at. Do not look at what facilities are available, etc., etc. And to me, a candidate will be given credit for answering very frankly. No need to read books. Go to your ward, examine the patient. His taking history is the key to success. That's my take. Thank you.
Thank you, sir. Nishi sir.
Sir, with textbook of Love Billy, we can pass MBBS, MS, MRCS, FRCS. But here teaching, learning and assessment method is different. So they should stick with assessment method. As sir already told that by referring 2 or 3 cases of the same parent, that is more than enough to pass or score the
Noted.
marks.
Noted, sir. Noted, sir.
So,
Right, sir, please.
For theory exam, I think the question bank is a big one. I also prepared that way. We used to take each question and answer it, and similar topics. We used to collect questions of similar topics and see what are the type of questions asked on the topic and answer them. That's a good way to practice. And it tells you which topics are more commonly asked, which are less commonly asked. So the more common ones, which are appearing more, that topic is appearing more number of times in, say, 500 questions, is to be paid more stress. For practical, like Sir said, Professor Dalby said, we always tell the students, you tell us what you do in the ward or what you do in your OPD. That is always the correct way. That is usually the correct way, unless it's gross. So, but if you start going to theory that I'm going to do a CT, angio or whatever, no, that comes much later. We don't do that. So I always say, you tell what you've been doing, and that's usually correct.
Sir, I'm going to touch a very important, sensitive question.
Right.
As an examiner, when you're correcting theory, or as a convener, when you're sitting for the final consolidation, do you give grace marks? If grace marks are given, on what basis the examiners consider, sir? This is a tough question, I know, but then I would like many students ask this sensitive question to me. Maybe each one of you can tell your viewpoints, how a candidate, a borderline candidate, is trying to be helped upon, sir.
So, Professor Khanna, you, sir, please.
I think, first of all thing, we always look as an external examination to the internal examiner. What is his mood? What does he think about that particular student which is there? Has he really worked good in the past 3 years or not? If the internal examiner says that he has done very good in the last 3 years, but it may just...
One moment. Yes, sir. Please, sir.
But it is only at that particular moment of 15 minutes when he's facing the exam, he has not done well. then definitely we are going to give the grace to that particular student. The second thing is we want to see that what is the percentage of passing which is there. If the passing percentage is more than 75%, that is my particular thing, then probably we do not think of giving any grace there. But if the passing percentage is falling down below 75%, so means out of 20 students, if 15 are passing and 5 are failing, I will say it's okay. It's a good result, which is there 75%. But if it is falling down than that, then we have to definitely make out some thinking about the grace marks. And I think the grace marks which has to be given, it has to be just a generalized thing, which means that not for a particular student, that we are giving the grace mark for that particular student. If we are going to give 5 grace marks,
It will be for all.
5 for everyone. It will be 5
Okay.
for everyone. It is not that for one student we are doing this. So I think these are the main criteria which is there, but we always, as an external examiner, we look at the internal examiner, that what is his assessment about that. And based on that, we are not very tough persons that we are just going to say that no. But if the student is good and he is not able to perform at that particular time, and it's not a big difference is there, it's a difference of 2 or 3 or 4 marks or 5 marks is there, then definitely we are going to give the grace to that particular one.
Thank you, sir. Rajiv sir, what is your practice?
So, like Sir said, if in a case most students have done well and a particular student has not done well in that case, but he's performed particularly well in other cases, then he deserves, and he's failing because of this case, the long case, then he deserves to be given grace marks.
True, sir. True.
But otherwise, I mean, it's not, unless it's just a mark, he's 49 and 50 is passed, then
Sure.
probably they can just give him a boot up,
Consider.
but not more than that.
Nishi sir, your thoughts before I'm going to give one closing question.
Sir, sometimes I also observed that most of the students, or sometimes few students, they are good in a long case, but they make some mistakes in major mistakes in a short case. So that is again, as sir said, that depend upon the internal. We have to hand over to the internal how he worked, what is, because they are the good person to judge their students. Definitely we can help you in such situations, sir.
That's very, very gratifying, and thank you very much, sir. One last question to each one of you. I've seen students, especially when sit as a convener, they don't do morning exams well. Sir, I didn't do long case well. I did one short case, and they don't want to appear for the afternoon. Is this the right approach, sir? Like afternoon, they have 4 stations of vivas, especially they sit with the instruments, operative surgery, all those things. And then some people definitely have ward round also. In National Board, we have ward round, and many universities are moving to ward rounds as well. A candidate who have not done well in clinical, like long case or something, does the examiners consider them in the afternoon if they are doing exceptionally well? Do you recommend, or do you consider them to for the morning's loss, sir?
Yeah, if the candidate is at the borderline in the morning session, okay, if he has, the main emphasis is on the long case. That is probably the number 1 which is there. Second is the short case. Third is the ward round, and 4th is the table viva which is there. So I think that is the order of priority according to me, Jay. The first is the long case, second is the short case, third is the ward round, and 4th is the table viva which is there. So if somebody is at the borderline in the long case is there, but he has done good in the short case, or even in the ward round he has done good, or he has done, definitely I will give the concession for that.
Point is well taken, sir. Any other inputs, sir? Nishi sir, please.
As our great Abdul Kalam sir, if you fail, never give up, because fail means first attempt in the learning. So this is beautiful quote. Fail means the first attempt in the learning. So there is no need of worrying. Passing and failing doesn't matter. Patient won't ask question to us.
Yes, sir. Yes, sir.
I just want to put in
Yes,
something.
sir.
Like I tell the students, in your theory exam, never miss a question until you don't know anything about it. Right? So initially what they do, they want to write everything about that question which they know. And later on, it comes down to just a trickle of few, or they miss the questions. And that's how they fail. So you have to judge your time according to the number of questions and attempt all questions. One question missed means you lose it's a great chance of failing. About practicals, it is not that they should be told that you have a chance of passing if you appear. If you don't appear, you're not giving the examiner a chance to pass you. You have to give the examiner a chance to pass you. So they have to, in national board, you cannot walk away actually. So, but in MS you can. You may not appear for the second round. In national board you can't. You're bound inside. You're not allowed to go out. So it's that way. But that's what I tell the students. Never miss a question and never miss an opportunity to let the examiner pass you. Because we are here to pass you rather than to fail you.
Yes, sir.
We start off with 50. If the student comes to the exam, we start off with 50%. If he answers a question, we give him 1 mark. If he doesn't answer, if he answers incorrectly, we deduct 1 mark. But we start off with 50.
Point is taken, sir. Point is well taken. So I think we had a good deliberation about the how to face the exams. I wish each one of you give your blessings, and we'll call the session a close. Starting from Abhay sir, your hands are going up.
Yeah, in my time it was 30%. It has increased to 50%. It's a good omen, because the type of work that our residents do during their 3-year career is which is substantial. I just want to go on record, since you have been conducting this, is type of questions which are asked. I will classify people into 4 types of questions which are asked to the candidate. Number 1 is whether he has worked in the ward. That's my way to look at it. And the other type of questions which are asked as irrelevant. Unfortunately, super specialty examiners come into picture and destroy everything which is happening in RRC. And how does one resident answer questions in 10 minutes or 20 minutes in a long case or short case is difficult. If I, as an examiner, have to put myself into this sort of examination that is taken for me, it's going to be impossible. So I think NMC has laid down guidelines. It's okay. But we have to be little lenient on asking the internal examiner how this person has worked. I have gone to multiple places as examiner to just pass candidates because they have been failed on some 1 or 2 points. And that is, and in their internal examination, they have been first. That's worrying for me. It should not happen. Thank you.
Sir, there has been one episode in last year's exam which I conducted. One candidate was third time appearing for the exam. As Rajiv sir said, the third time if they fail the clinical exam, they have to appear for one more theory exam. That's how the national board works. Candidate was given a case of mass in the abdomen. It was a retroperitoneal tumor. The candidate said, sir, you please give any other case, sir. I'm appearing for the third time. Are as examiners, are we permitted to change the case after the case is being allotted, sir? What does the guideline tell, sir?
So I will tell you very frankly, theory actually decides everything.
Yes, sir.
In my time, practical would decide everything. Theory never decides. So let's keep it aside. So theory also, it is written, examined by people, it's okay. Practical examination, examiners, if at all they have controversy in the diagnosis becomes a big problem. And at least two of the examiners should support the candidate for the examination findings, and two can go. That is exactly what people are trying to say, that the convener has to decide how it is defended. And if at all the defense is this, even if diagnosis is wrong, I will give you my own example. In 1984, when I appeared for MS examination, I had a lump in epigastrium. I felt it was hydrated, but the examiners, two or three examiners, did not agree. They thought it was pseudocyst. And then I was about to fail. But luckily, in short cases, I did well and I passed. So it's a very tricky situation where I personally feel examiners to get together and decide what is the final diagnosis and then come to the table to examine a candidate. That's my take. Thank you.
Thank you, sir. So,
So,
yes, sir,
yeah,
please.
I feel like you said, the student said he doesn't want a retropreneur. It is not the diagnosis which is important. It is the process by which he reaches the diagnosis which is important. So he may not be knowing anything about retroperitoneal, no problems, but he should be able to distinguish the slump from the retroperitoneal lump, or why is it. The whole process of taking history, and that is most important, and that is what we judge rather than the diagnosis. I know in previous we also had this, that the student thought it's hydrolysis, and the examiner thinks it's that's we've got modern guys. No one depends. Everyone goes for ultrasound. Everyone goes for CT. So if a person cannot say that there is minimal ascites or moderate ascites, fine. No issues about it. If we can't, because we use ultrasound these days. It is a sine qua non for any examination. So it doesn't matter that he can't show shifting dullness or something. Fine. He knows the process. He may not know it exactly. We have to let go of this, of our past, and move to the modern times when ultrasound and CT are the usual things. At first, we used to laugh, why CT first? No, I think it's the norm. So we got to let go of our past now.
Point is taken, sir.
I completely agree with you, sir. The question is, with investigations allowed today, which were not during your time or my time, it's very clear that the candidates or the residents are sending patients for ultrasound and CT scan even before examining and taking history of the patient.
That is wrong.
My objection.
Yes, that is wrong. That's wrong.
That's my objection.
That is not acceptable. That is not acceptable.
I've been going to places teaching even now, and I realize that the residents are not even examining the patients but showing CT scans. The unfortunate part is the radiologist is not able to tell me what he or she is looking at. That is the problem. The communication between history taking, clinical examination, investigations by a resident doctor in surgery and resident doctor in radiology is gone to dogs.
And yes, I agree completely with that. Absolutely right, sir.
Yeah. Okay. Absolutely. Thank you so much.
Thank you, sir. I think I would request each one of you to bless the children who are going to appear for the exams, and then we'll call it close. Nishi sir.
Sir, one more point. Now NMC also sensitizing most of the faculties, all the faculties with revised basic course, CISP, ATCOM and ACME. So previously it was not compulsory. Now they made compulsory. So assessment is also improved, sir. With this, in our time, they used to ask some questions with the two answers. For example, how much percentage of the thyroid malignancy undergoes the hyperthyroidism goes malignancy. Hyperthyroidism cases goes the malignancy. Like such questions. In some previously in the last edition, it was 3%, now 5%. So such questions should not be asked. That is clear-cut guidelines given in by the NMC, sir.
Thank you, sir. Thank you.
Thank you, sir.
I think we will call the session a close. I wish all of you give your blessings to the children, because many universities have started theory exams. At least in our state, we have starting in another 15 days. The National Board has completed theory exams for the earlier batch, and the next batch is giving in December 2nd week. So I wish all of you give your blessings, and we will call the session a close.
Definitely, sir.
Thank you, sir.
All the best, everyone.
I think the students must know that examiners are always there to help. They are always want that they will pass you, jo hai na? Probably none of the examiner, or very, very rarely, the examiner will go there to fail a student, jo hai na? So that you should carry in all the students must carry in your mind that the person who is sitting in front of you is for the help and not for your loss, jo hai na?
Thank you, sir.
Thank you.
Rajiv, sir.
Right. So I think it's what sir says is right. We should go to the examinations with an open mind and a positive mind that we want to help the students to pass in theory and practical, but you got to help us to help you pass. You can't put in a blank paper and say, please help me.
I understand. You do your part, the examiners will do their part. I'm getting
You do
it right.
one, we'll do two. But if you do 0, multiplied by my 2 will be again 0.
Correct. Nishi, sir?
Sir, as sir said, no examiner will come with the intention of failing the student. So they are always there to help the student, sir. So no need to worry.
Thank you, sir. Thank you. With the permission of the faculty, I will call the session a close. I once again apologize for the students for could not continue with the clinical case discussion for this week. And I am sure I also feel the examiners have, the faculty here have definitely spent the time worthwhile giving you appropriate advice and removing your doubts who are preparing for the primary exam or in these repeat examiners. And on everyone's behalf, I wish you all the best. Those who are appearing for theory or those who are appearing for clinical examination, do well and all the best to you. And with the permission of the faculty, I'll call a session a close. Thank you very much and good night, everyone.
Good night, sir.
Good night, sir.
Good night, sir.